Hello, my name is Thao and I'm from California North State University, class of 2023. In this video, I will be talking about heparin products, which are unfractionated heparin and low molecular weight heparin. Administration for heparin and or low molecular weight heparins are done subcutaneously or under the skin injection for most patients outside the hospital. This slide will talk about the method of self-administering these medications. Before handling and injecting the medication, make sure to wash your hands with soap and water thoroughly. Disinfect your area of injection with an alcohol swab and let it air dry completely before injecting the medication. Next, you will pick a site for the injection. Make sure to rotate each injection site each time. With Lovenox, injection can be done in the love handle position or the size of your abdomen, at least 2 inches away from your belly button as shown in the top picture. For heparin and Dalteparin, the medication can be injected in the U-shaped area around the navel, the upper outer side of the thigh, or upper outer quadrangle of the buttock. When you're ready to inject the medication, pinch your skin to make a fold as seen in the picture to the right with one hand, and then hold the open syringe like a pencil with the other hand. Insert the full length of the needle at a 90-degree angle into the folded skin. Press the plunger with your thumb until the syringe is empty. Pull the needle out at the same 90-degree angle. Activate safety features if it is available to you, and dispose of the needle in the sharp container. Unfractionated heparin, or just heparin for short, is a common anticoagulant used in treating and preventing blood clot formation that results in venous thromboembolism, or VTE. It is widely used in the inpatient setting for medical and surgical patients. Although it can be rare, heparin can be used as outpatient and is available in prefilled syringes and solution for subcutaneous injection. Low molecular weight heparin are depolymerized standard heparin or fragments of heparin that are more commonly used outpatient than heparin itself. In the US, we have Enoxaparin or Lovenox and Dalteparin or fragment. Both of these medications are available in single-dose prefilled syringes or graduated prefilled syringes, which allows for injection of less than the package size dose. They also come in multi-dose vials of about 3 milliliters per vial. Here's a look at the advantages and disadvantages of each agent. Heparin is cheap and it can be used widely, especially inpatient. Its fast-acting and fast-eliminating property allows for more freedom in administration, especially when a procedure is pending. Heparin does not need to be renally adjusted. However, heparin may need more frequent administration. Of all three agents, heparin has the biggest chance of producing heparin-induced thrombocytopenia. Both Lovenox and fragment can be dosed less frequently, and Lovenox is a popular anticoagulant for outpatient use. However, there is a renal dose adjustment requirement for patients with reduced renal function. Dalteparin or fragment can be less popular as it is more expensive than heparin and Lovenox. Patients with creatinine clearance less than 30 is not recommended to use fragment. Across the board, these products can be used in pregnancy. Those with known hypersensitivity to heparin products or pork should not use these products. Let's take a look at the mechanism of action for these heparin products. In the coagulation cascade, heparin inactivates factor 2A, which is thrombin factor from the extrinsic pathway, and factors 9A, 10A, 11A, and 12A in the intrinsic pathway to inhibit the formation of a stable fibrin and prevent clot formation. Similarly to heparin, low molecular weight heparin strongly inhibits factor 10A, but it inhibits factors 2A to a much lesser degree to prevent clot formation. In this slide, I will talk about dosing guidance for unfractionated heparin. In outpatient setting, heparin can be used in pregnant women and doses is adjusted according to the trimester. A higher dose is required in high-risk patients. APTT level should be monitored frequently to guide dose adjustment. Heparin should be discontinued at the onset of spontaneous labor or at least 12 hours or 24 hours before planned induction of labor, depending on the dose the patient is receiving. Patients can be restarted on heparin, especially if risk factors remain postpartum up to 6 weeks or longer. In the treatment of DVT and or PE outpatient, heparin can be initiated at 333 units per kilograms, then followed by 250 units per kilogram every 12 hours. For enoxaparin, patient can be dosed at 40 milligrams subcutaneously daily for most VTE prophylaxis cases, except for total hip arthroplasty, where a patient can be dosed at 40 milligrams subcutaneously once daily or 30 milligrams every 12 hours for a minimum of 10 to 14 days and up to 35 days. In total knee arthroplasty, patients should be dosed at 30 milligrams subcutaneously every 12 hours for a minimum of 10 to 14 days and up to 35 days. In any case, patients with reduced renal function should receive 30 milligrams subcutaneously once daily. In treatment of VTE, patients should receive full therapeutic dose at 1 milligram per kilogram subcutaneously every 12 hours or 1.5 milligrams per kilogram every 24 hours. Unless they have reduced renal function, then the dose can be reduced to 1 milligrams per kilogram subcutaneously once daily. And the duration of treatment is at least 3 months, depending on whether each case is a provoked or unprovoked VTE and risk factors for recurrence and bleeding. In pregnant women, treatment dose is still 1 milligrams per kilogram subcutaneously every 12 hours for a total of at least 3 to 6 months with at least 6 weeks postpartums, whereas prophylaxis dose is 40 milligrams subcutaneously every 24 hours. To transition from an anticoagulant such as unfractionated heparin to enoxaparin, discontinue unfractionated heparin and begin enoxaparin within 1 hour. From treatment dose of enoxaparin to an IV heparin at a treatment dose, start 1 to 2 hours before the next dose of enoxaparin that would have been dosed. Omit the loading dose for heparin. From prophylaxis enoxaparin dose to treatment dose for IV heparin, start IV heparin immediately with loading dose, and to transition from treatment dose of enoxaparin to warfarin, start warfarin and continue enoxaparin until INR is within therapeutic range, and overlap until INR is over 2 for at least 2 measurements taken 24 hours apart, and it is usually 4 to 5 days bridging. From treatment dose of enoxaparin to any oral anticoagulant, start a DOAC within 2 hours prior to the next scheduled dose of enoxaparin. Here's a look at all the dosing guidance for Dalteparin. In VTE prophylaxis, the usual dose is 5,000 units subcutaneously once daily, and in pregnancy, dose intensity should be individualized based on risk of thrombosis and bleeding complications. VTE treatment dose should be 200 units per kilogram subcutaneous once daily, or 100 units per kilogram every 12 hours. Treatment duration is about 3 months if this DVT case was provoked and the provoking factor is no longer present. Treatment duration can be longer in patients with unprovoked VTE episode or if provoking factor persists. VTE treatment in active cancer patients is 200 units per kilograms daily for 30 days, and then 150 units per kilogram daily for 2 to 6 months, after which risk will be reassessed and continue treatment as appropriate. Adjust dose based on platelet count in cases of thrombocytopenia. In patients with creatinine clearance of less than 30 milliliter per minute, they are not recommended to use Dalteparin. To transition with Dalteparin from an anticoagulant, such as a treatment dose of IV heparin, we can discontinue heparin and begin Dalteparin within 1 hour. And from a treatment dose of Dalteparin to an IV heparin treatment dose, start IV heparin 1 to 2 hours before the next dose of Dalteparin. From a prophylaxis dose of Dalteparin to an IV treatment dose of heparin, start without delay, and then with or without a loading dose. From treatment dose of Dalteparin to warfarin, we can start warfarin and continue Dalteparin until INR is within therapeutic range. Overlap Dalteparin and warfarin until INR is above 2 for at least 2 measurements taken about 24 hours apart, which is about 5 days. Dalteparin at treatment dose to a DOAC. We can start DOAC within 2 hours prior to the next scheduled dose of Dalteparin. Some monitoring parameters should be considered and performed regularly in patients receiving any of the mentioned heparin products. Activated partial thromboplastin clotting time, or APTT, should be monitored regularly in patients receiving heparin, whereas anti-factor XA activity should be monitored in patients receiving low molecular weight heparin. Platelet count is especially important in detecting a thrombocytopenia event, and it should be monitored regularly. On top of that, patients should be monitored for hemoglobin level, hematocrit level, kidney function, and any signs and symptoms of a bleeding event, such as blood in stool or blood in urine, just to name a few. Here's a look at some of the side effects of heparin and low molecular weight heparin. All heparin products carry a risk of producing heparin-induced thrombocytopenia. All patients who receive heparin or low molecular weight heparin, they should be monitored for these side effects. A common side effect seen in all 3 products are increased in liver enzyme and major hemorrhage, which may occur in some patients. Those who receive Enoxaparin may experience some GI disturbances as well. Here's a look at some of the contraindications to heparin or low molecular weight heparin products. With patients receiving treatment dose heparin, blood coagulation tests needs to be performed regularly. Therefore, it is a contraindication if access to these tests cannot be established. In patients with severe thrombocytopenia, they're contraindicated to receive heparin, and while those with HIT are generally contraindicated to receive low molecular weight heparin. Those allergic to or are contraindicated to use benzyl alcohol, they are also contraindicated to use heparin and enoxaparin. Other contraindications include active uncontrolled bleeding, patients with cardiac complications during an epidural or neuraxial anesthesia procedure, or sensitivity to heparin or pork products. Low molecular weight heparin products such as Enoxaparin and Dalteparin carry a black box warning for which incidents of hematoma may occur in anticoagulated patients and are receiving neuraxial anesthesia or undergoing spinal puncture. These patients have risk factors such as indwelling epidural catheters, concomitant use of NSAIDs, platelet inhibitors, other anticoagulants, or have a history of traumatic or repeated epidural or spinal punctures, or they have history of spinal deformity or injury. These hematomas can result in long-term or permanent paralysis. And that concludes my presentation, and here are my references. And thank you for tuning in.